We have with us, she's pregnant at 27 weeks. And I'm going to start, I usually start by looking at the presentation of the fetus. Can you see? Looking good? Okay. So we have a cephalic presentation. So I'm angling towards the lower pelvis as I come up. So we have a cephalic presentation. And then I'll find where the spine is. So I'm going to slide up. And the spine is left side. So knowing that, I know that the left side is down of the fetus based on the baby is in a longitudinal lie first. So I can get a sagittal view of the spine by going totally towards left side. And this is a mid-sagittal view of spine. So I know that the baby is in orientation in a longitudinal lie because the baby's spine is parallel to the maternal spine. So, after I establish the presentation and the lie of the fetus, I establish the situs, knowing here that the left side of the fetus is going to be down. So I look at the heart while I'm going down transversely now. I look at the cardiac axis also. I don't measure on every scan, but I semi-quantitated by looking at it. See, this is about 45 degrees. So this is a normal cardiac axis, and the apex of the heart is on the left side. So let me just rest my arm here. So that's apex of the heart, cardiac axis. And I also look at the descending aorta, a very important part. We'll talk about this when we talk about aortic arch abnormalities. You see, this is if I bisect that chest into two halves, that descending aorta is on the left side. So that's a left aortic arch, normal aortic arch. Then I'm going to slide into the abdomen. So I'm sliding towards the baby's feet. So here I want to see the stomach on the left side. I see the descending aorta on the left side of the spine, and I see the inferior vena cava on the right side. So very important to do, and to get a perfect transverse views of the abdomen and chest, if you look, I have nice almost full ribs on each side. That tells you that you are in an almost perfect transverse view. So as I look at the abdominal situs, I see the umbilical vein coming in. I see the venous system in the liver, but I also always look to see the gallbladder in the fetus. And I want to see the gallbladder on the right side of the abdomen. Important when you're dealing with heterotaxy to make sure the baby, you're not dealing with problems related to the biliary system in the fetus, because that certainly changes the prognosis substantially. So I have a normal situs in the fetus. Then I'm going to slide back up into the chest. So given that the left side is down, I'm going to try to work a little bit before I improve my image and I make it look back. I'm going to slide. You see how I'm coming into the heart through the ribs. So I'm going to try to see if I can image the heart with the ultrasound beam coming away from the ribs to minimize shadowing, but also to help me get to an axial view of the heart. So this is what we call a basal view, or coming from the base of the heart. It's good to look at the pulmonary veins, so you can see them here even on grayscale. This is left atrium, right atrium, left ventricle, right ventricle, descending aorta, right? So that's first orientation. So I'm going to slide my transducer on the abdomen, and I'm going to come back into a window, an acoustic window, that gives me almost a transverse view. So here I'm going to reduce the depth. Now I'm going to narrow the sector width. Now that I've found a nice acoustic window to get in. And I'm going to, so here this allows me to evaluate the ventricles. So I could look at the contractility. This is the left ventricle right here. Look at the apex. It's apex forming, forms the apex of the heart. Nice and smooth on the inside, described as bullet-shaped. And you see the contractility is nice and equal. And I also look at the septum to make sure there's no abnormal contractility of the septum. So the septum is moving like nicely between the two. Then I'm going to look at the right ventricle here. See that the borders is more coarse. Now before maybe we can, why don't you magnify? Just going to go in. Yeah, okay, let's do that for now. Oops, sorry. Let me get the pointer back again. And you see that the wall of the right ventricle is more coarser than the wall of the left ventricle. Now, another important feature is looking at the insertion of the chordae tendineae, and I'll see if I can get to that. Maybe reduce the gain just a tiny bit. Okay, that's pretty good, thank you. So, and I'll get to that in a bit. There's septal insertion of the chordae tendineae in the right ventricle, a feature that is not available in the left. All the cords that come from the mitral valve inserts into the two papillary muscles in the left side, whereas in the right side, as you know, there's three papillary muscles, but there's some free cords that inserts into the wall. This becomes important if you're trying to determine situs of ventricle. So I'm going to come in a little bit at an angle. Now I'm going to look at the atrial and ventricular septum. I'm going to look at the atrial septum right here. This is the septum primum area. I want to see that this is intact. Here's your foramen ovale, and you see the leaflet of the foramen nicely opening from right to left. And then I'm going to look at the ventricular septum. So I'm going to look at the integrity of the septum here in the four-chamber view, at least on 2D. Then we'll try to look at color, and I'll show you. That's the most probably optimal way to look at the septum on color Doppler, because it allows you to detect very small muscular VSDs. You see blood flow across, because you're parallel to the orientation of flow. So your cosine in the Doppler equation of 0 degrees equal 1. So you actually are not attenuating any blood flow by doing that way. So atrial size is equal. The foramen ovale open. Septum primum area is equal. I see the septal leaflet, the insertion of the tricuspid valve, the septal leaflet, the mitral valve right here. They're opening and closing very nicely, synchronously. There's no thickening along the AV valves. So that looks very nice, a normal heart at the four-chamber view. Now I'll come back to the pulmonary veins later. But indeed, what's important also, look at the descending aorta. It's on the left side of the spine. No blood vessel between the descending aorta and the posterior wall of the left atrium. Very important feature, because if you see any abnormal vessel right here, you should start suspecting anomalous venous return, because all of them collect into a vessel here and either drain upward towards the SVC or straight into the heart, to the coronary sinus or the right ventricle, or down to the inferior vena cava to come back through a vertical vein. So by looking at this area here, that's really critical. Make sure you don't see any abnormal vessels between the aorta and the posterior wall of the ventricle. So now I'm going to work a little bit on the four-chamber view. So I'm going to the five-chamber view. So I'm going to angle to get the left ventricular outflow tract, and I'm going to discuss several features of this view right here. So first, I want you to see the angle that the ascending aorta makes with the ventricular septum. You see there's a nice slight angle, about 20 or 30 degrees, that the ascending aorta makes with the normal, in the normal heart with the ventricular septum. I'll show you tomorrow when we talk about conotruncal anomaly tetralogy of Fallot that this is lost. This angle is lost when you have aortic override. So that's a very important feature to keep in mind. Second, I want you, as you look at the ascending aorta, look at the aortic valve. And here I'm going to freeze, and I'm going to cine loop back. And you see when the valves are open, you don't see any leaflets at the level of the valve annulus. I think that's important. You see right here, it's totally clear, and I don't see any leaflets. In mild aortic stenosis, one of the features is you still see some valve leaflets that can't open all the way into the heart. That should be your clue to look at. The third thing you need to look for is when you look at the ascending aorta, look at the size of the aorta. It should be uniform throughout as it comes out. Many times with aortic stenosis, you have post-stenotic dilation of the vessel, so you have ballooning of the vessel after the valve annulus. And you look here, it's nice and clear. The fourth feature, which I believe is the most important feature, is to make sure that this vessel that comes out from the left ventricle does not divide right at this level, because that will give you a clue that this is a pulmonary artery and indeed you have transposition. So in many times, transposition is missed because what you see is we are focusing on this area here to make sure there's no override, and then we miss the fact that the vessel divides right at this level. So learn to look at the vessel all the way, make sure there's no division of the aorta as it comes out. So these are the features of the left ventricular outflow tract, and I really want to emphasize how critical it is every time you do so to really look at all these features to make sure you're not missing anything. So from this LVOT, the other area that's of interest is the perimembranous area of the septum. If you remember from Elena's talk, this is where the perimembranous ventricular septal defects happen. You suspect them on 2D, but then you confirm them on color, showing some blood flow coming from the right ventricle straight into the ascending aorta at this level. The other important feature of this view is look at the continuity between the mitral valve and the aortic valve. They are in the same plane, and there's this important anatomic continuity is really what you look for when you're talking about double outlet right ventricle and so forth, where you lose this anatomic proximity and continuity between the two. So this mitral valve blood coming in, going out through the aorta in the same anatomic plane. This feature is not available in the right ventricle. Inflow into the right ventricle is in one plane, and outflow is in a totally more anterior plane. So that's why this is the left ventricle has this feature that's not present in the right ventricle. So from the LVOT, I'm going to angle up to look at the right ventricular outflow tract. And let me angle a little bit to show you the valve. Here you go. So here's the right ventricle, pulmonary artery right here. Here's the ascending pulmonary artery here, and then it's going into the ductal arch at this level. So again, same features. You look at the pulmonary valve, make sure it doesn't go away. During systole, you look at the shape of the vessel. It should be slightly larger than the aorta. And as I go into the transverse views in the upper chest, you will see how we can assess the size of the vessel. So let me do that now. So I'm going to come up here a little bit, and let me get my hand on the freeze. So there are several axial views that you do coming up from the 5-chamber view. The first one is the ductal arch view. Actually, the 3-vessel here. Let me just. First one is the 3-vessel view, where you see the aorta, the pulmonary artery dividing into the right pulmonary artery that goes under the aorta and the left pulmonary artery at this level. If I slide more higher in the chest, I'm going to get the ductal arch view. This is when you see the descending, the pulmonary artery going straight down, and the aorta is on cross-section. Let me turn a little bit to get that view. I have to angle. And then if you still slide up, you get the 3-vessel trachea view. And we're going to talk a lot about the 3-vessel trachea view, as you see right here. So what you should see in the 3-vessel trachea view, and I'm doing this all with grayscale, and I'll add color. And because there's a session on color, I don't want to do a lot of color, but I'll show you once we move into that. You have the pulmonary artery, ductal arch, the ascending aorta here, aortic isthmus, and the superior vena cava. And you see the azygous vein coming into the superior vena cava here, and you see a cross-section of the trachea. And you see that this arch is coming to the left side of the trachea, so you have a normal left-sided aortic arch. Very, very important view. You'll see tomorrow when we talk about conotruncal anomalies. This is the view that would allow you to really suspect the presence of transposition, double outlets, tetralogy, and all those. And they have special features. We have a special session on that to talk about that. And here you see again the relationship. Now, if I keep sliding up into the chest, there are 2 important planes that are beyond this one. One is the transverse arch view. And you have to be careful not to confuse the transverse arch view with an abnormal 3-vessel trachea view. Here, you will, because you are so anterior in the chest, so high up, you just get the top of the aortic arch coming down with a cross-section of the superior vena cava. Okay? So that is a plane that is normal. That's you're very high up in the chest. And be careful that this is called the transverse arch view. And then if you slide slightly above that, you'll see what we call the brachiocephalic vein. And here's the brachiocephalic vein right here that connects the right side of the drainage from the brain to the left side, to the right-sided superior vena cava. Okay, and this is here behind it is the thymus gland that you see in this level right here. So these are the planes going up in the chest. I highly recommend that you become very competent in looking at the 3-vessel trachea view, because it certainly helps you in making a lot of diagnosis. So the baby is helping me now. And so now that allows me, let me just magnify a little bit less, because I want to work on the arches. And then, so to see the aortic arch structure, I need to be in an almost sagittal view of the spine. So I'm going to try to come in from mom's side. And here's your aortic arch right here, even on grayscale. You see the nice curvature, nice size throughout, and you see the right aortic, the right pulmonary artery coming right under it. So this is the ductal arch view here. I'm going in and out. I have shadowing from the extremity on top. So I'm going to try to change my angle to see if I come in through a window that there's no shadowing. So here's the aortic arch. It's a nice candy cane in appearance with the head and neck vessels. Okay, and this is the right, this is the right pulmonary artery coming under. See the head and neck vessels here. And in this view, if I slide a little bit to the right parasagittal plane, I see the IVC and the SVC coming into the right atrium. And then the ductal arch is so in between. So you have IVC coming into the right atrium, you have the ductal arch view, and then if you go to the left side, you get the aortic arch view. So let me turn and see how the baby is sitting here. So let's do some color now after. So I'm going to change a little bit of where we are. Okay, I'm going to give myself a little bit more depth, maybe increase the gain just slightly, and then let's magnify. So if you look throughout the course, many of the images are quite magnified. That really allows you to look at the heart in more details. So I'm going to go ahead and put some color coming through the LVOT. Again, here you're looking at laminar flow coming through the left ventricle. Maybe I'll make the color box smaller. That would increase your frame rate. So you see I'm working with a 21 hertz frame rate now. As I reduce, always use the smallest color box possible that you need. That would really allow you to even maybe make it a bit smaller. Yeah, go ahead. That would allow you to keep your frame rate higher. Yeah, that's pretty good. So here you see the ascending aorta here, nice laminar flow coming out. So I'm going to angle towards the 3-vessel trachea view. I'm going to increase the PRF a little bit here, so because the flow is a higher velocity in these vessels, and maybe I'll make the box just a little bit bigger, just to give a perspective of where I am. So here you have to see blood flow in similar directions between the ductal arch and the aortic arch. Yeah, okay. So we have, I'll tell you, maybe without magnification, just go back because our frame rate is, so yeah, this is better, frame rate is so low. So here you see again the ductal arch and the aortic arch here coming together. If I slide, here's the brachiocephalic vein. You see that, so the blood is going up because we're going from left to right, as you see between the two. And then if I go back to the level of the 4-chamber view, you know, mild tricuspid regurg is usually normal, but you need to see 2 channels that's bringing blood into the ventricles that are distinct. Okay, and then here in the right ventricle, because the left ventricle, because the aorta and the mitral valve are in the same plane, you'll see actually the blood coming out. So I'm going to turn a little bit with the baby. Now I'm going to show you the pulmonary veins. So I'm going to do 2 things. First, I'm going to reduce the depth here. The other way. Thank you. I'm going to reduce the color box. And then I'm going to reduce also the velocity scale, because remember, we're looking at venous flow. So, and then I'm going to focus on the back wall of the, and then we can increase the gain and reduce the velocity scale 1 more. Okay, so you see the pulmonary arteries coming out, and next to it is the pulmonary vein in blue, bringing blood to the back wall of the left atrium right here. And you see it, I'm trying to isolate it alone. And now if I can put the pulse Doppler on it. There you go. Okay, and that's the typical normal pulse Doppler that you get from, you have the pulmonary artery on top, but here's the pulmonary vein. Remember in Dr. Rychek's presentation that when you look at restrictive foramen ovale, the atrial wave component will be in reverse flow. So you see we have forward flow throughout the pulmonary vein here, but if you have components that have reverse flow, that is suggestive of a restrictive foramen ovale. So I'm gonna, you can get me out of that. So here, again, ascending aorta. This is the pulmonary artery. Again, normal flow in the pulmonary artery through the pulmonary valve, and then into the 3-vessel trachea view, and then the brachiocephalic. That's the red vessel here that you see right in a higher transverse plane of the chest. Okay, how are we doing on time? Okay, so let me just do maybe one more thing and then we'll stop. So I'm going to go back to 2D. So as you see, the baby is when the baby is presenting in a left side down as is. You can take me back to the other presets. Oh, thanks. If the baby is presenting left side down like this, I'll try to get in to access the heart from different planes. So as I mentioned, now I see no extremities here, so I can actually slide a little bit to avoid shadowing. So you could see actually, if you notice, where the shadowing from the rib is taking you. So I can try to avoid that by coming from the abdomen and angling into the heart. That gives you much more visibility. And many times you can do an internal rotation of the baby. And no, I'm joking, but the baby turned for you. And you can see the planes right here. Now, to be able to get, and also now the azygous vein you can see on many occasions in the normal fetus. So the azygous vein is this tiny vein that is typically situated next to the descending aorta, okay? And now we saw it as it connects with the superior vena cava at this level. Let me see if I can get it through. And you see a portion of it right here coming into the superior vena. You can actually see it from the first trimester if you look for it. The key is it has to be certainly smaller than the aorta. Normally, it's about 1/3 the size of the aorta. When you start seeing a large vessel sitting next to the aorta here, then you have to be very suspicious that there's an interruption of the inferior vena cava. Typically, the interruption is suprarenal. And then there is an azygous continuity that the systemic venous system is coming up through the azygous vein and dumping into the superior vena cava, most commonly at the level of the heart. And so it's really important when you look at the heart, whether you're doing screening or you're doing your echo exam, that look at all these important structures around, because it can give you a lot of suspicion for the presence of an abnormality here. And this is here you actually see the brachiocephalic vein dumping into the superior vena cava. So I'm very, very high in the chest. I'm going to come down slightly here in the upper chest, and I see the ductal arch right here, the aortic arch right here, aortic isthmus, ductal arch. And then you have to angle a little bit to get the 3-vessel view with the division of the pulmonary artery. So these are the planes that I think at the level that you are at, my recommendation is to become very proficient in them, because it would help you tremendously in ruling out major abnormalities, especially related to transposition and all these things, because it's so critical. Many of those, when I go and look back at many of the transpositions that have been missed, many times you see that the division of the pulmonary artery, which could be very, very subtle at this level, is missed. Okay, so why don't I stop now?